Good evening, everyone. Welcome to another special episode of the Apex of Training and Development Cancer Awareness Program. I'm your host, Charian Casimir Hudge. This evening's program is sponsored by Nagico Insurances. Nagico Insurances are located in 21 territories across the Caribbean, as far north as the Bahamas and as far south as the ABC Islands. To learn more about the services offered by Nagico Insurances, you could visit their website at www.nagico.com. Tonight, we have a very special panel here with us to discuss the holistic aspect of cancer care. We have in our midst Miss Cora Norton, who is an author and a counselor, and we also have Dr. Andre Peters, a physiotherapist at the Celeste Bird Medical Center in Antigua and Barbuda. Good evening, ladies and gentlemen, and welcome, welcome, welcome. Welcome also to those of you who are joining us via our social media platforms, Facebook, YouTube, and Twitter. Remember to share the live, tell a family member, tell a friend, and tell a coworker that the apex of training and development is bringing you much needed insight on cancer awareness. Now, before we delve into tonight's discussion, I'm going to ask Miss Norton to tell us a little bit about herself. We know that you're an author and a counselor, but who who is Miss Norton for persons who are not familiar with you?
Okay, good evening to Miss Casimir Hodge and good evening, Dr. Peters. It's very
Good
good to
evening.
see both of you again.
Good to
And good
see you too.
evening to all, yes, thank you. Good evening to all our listeners. It's always a pleasure when we can get together to speak about issues that impact everybody in Antigua and Barbuda because it's such a small place. There's not a lot of degrees of separation. So everything that we discuss impacts somebody or somebody that you know. As Miss Casimir Hodge said, my name is Corinne Norton. I was previously a social worker at what was the then Mountain John's Medical Center. So for 10 years, I was in healthcare, social work. And during that time, I did counseling, and now I'm not at the hospital anymore. I still continue to do counseling. I work with all populations, and my mission, my personal mission statement, is to brighten the corner where I am and to do my part to help people to live more fulfilled lives. So I'm very pleased to be here with you today, or this evening actually, and I look forward to your questions and to a robust discussion.
Thank you so much, Miss Norton, and we're definitely happy to have you. And just to let you know that we're not limited to Antigua and Barbuda, we have persons throughout the Caribbean viewing tonight's show. And Dr. Adrian Peters, you are new to the Cancer Awareness Program. Tell us a little bit about yourself.
Good night, everyone, all viewers. I am Andre Peters. I got my bachelor's in physical therapy from UWI Mona, and then I did my transitional doctorate with Utica College. And basically, I have been practicing physiotherapy for, I'd say, roughly seven or so years. Um, Physiotherapy is a very important aspect of care, healthcare. It is basically the focus on functionality, movement, task, and basically managing any condition or symptoms which can impede such functioning and task. I consider myself a people's person. I find it an honor to actually work with persons in need. And by practicing physiotherapy, it allows me to actually reach out to quite a large number of persons with various conditions and ailments, cancer included.
Thank you, Dr. Andrew. We just want to say good evening to Roberta Ephraim. Good evening, and thank you for tuning in. Now, Miss Norton, we're going to get into tonight's discussion. And you are a counselor and author. You would have worked with persons at the then Mount St. John Medical Center, cancer patients. What type of support is needed for persons who have been diagnosed with cancer?
You see, we only have an hour for this show, and I could answer this question and take the entire hour, but I'll try to be very concise. But generally speaking, when someone is diagnosed with cancer, one of the first things we always try to ensure that they have is a support system. Around the Caribbean, around the world, one of the things that's able to get us through rough times is having people that we can count on. So when we look at cancer care, we have a continuum from diagnosis, then there's treatment, and then there's the survivorship aspect of it. Throughout the lifespan of cancer, persons need support. They need psychosocial support in terms of their emotional wellness, the physical aspect of it, the spiritual aspect, the financial aspect, the relationship aspect, the work aspect. So while the physicians and the nurses and the care team focus a lot on the clinical medical aspect of care, which is of utmost importance, studies have shown that patients do way better when they have a greater level of psychosocial support so that the care is holistic mind, body, and soul.
Ms. Norton, Dr. Andre, you are in the field of physiotherapy. Why do cancer patients need to undergo physiotherapy?
No, physical therapy is applicable to the patients either before treatment for the effects of the cancer itself, during treatment for cancer, and post treatment for cancer. So we can break it up into three different timelines, so to speak. Now, we most typically called in or referred to by the physicians post treatment and maybe late stages of treatment. So we are actually working to help the patient continue to function as much as possible. Um, Fatigue is usually one of the symptoms of cancer, or one of the symptoms that patients who are diagnosed with cancer can suffer from, both from the effects of the cancer itself and, of course, from the chemotherapy or radiotherapy treatment that they would be privy to. Then they may also be feeling pain again, as well as weakness, depending on the type of tumor. It could be even neurological in nature. So they'll have like dizziness, balance issues, so to speak. And post surgery, they may have what you call contractures, which is basically the tightening of muscles, soft tissue in general, that can restrict joint movement. So we are actually now working with each of these symptoms and conditions to try and help maintain the functionality of the patient, keep them moving, keep them performing tasks that sometimes we take granted for everyday tasks.
In terms of the immune system of the patient, does that play a role in the type of treatment they receive under your care?
In terms of the immune system, well, that is generally a matter that the oncologist that would take up. Um, I wouldn't really say that the immune system is a big part of what we manage, but we are always mindful to prevent any infection because, yes, they can be immunocompromised as a result of treatment or even the cancer itself. So we're always very careful in keeping our hands clean, preventing, any wounds or any breaks in the skin.
All right, thank you so much. Miss Norton, in your experience working at the Denmark St. John Medical Center, what type of patients were referred to you, cancer patients? What were some of the situations you would have encountered back then?
Okay, so I've seen patients starting with children who had tumors in their stomach or in their head, which was extremely difficult to see persons so young suffering so much. And then we've had not as many adolescents, but a few. And then the most of the persons I've seen were like late 20s going into 30s, 40s, 50s. And then we had a few patients who were elderly. So we had all ages of patients and the types of cancers we had, like I said, were head tumors, we had stomach cancers. I don't know all the names of them, We had a lot of females with breast cancer. I did not encounter any males with breast cancer, although they can have that. We had some females with cervical cancer, and those were the most popular ones, the breast, the cervical, and in men a lot, we saw prostate cancer. So a lot of the cancers we saw were based on age, certain age groups, certain sexes, and that sort of thing. And the treatments in terms of the psychosocial approach, it would vary depending on the age of the patient, depending on the type of cancer that they were suffering with or being treated for, and so that played a role. The sex, the age, the type of cancer, the assessment and the psychosocial treatment would differ depending on some of those factors.
And what was the mental state of patients, the younger patients, probably between 20 and 35 after being diagnosed with cancer when
It's
they came to
devastating.
you? Mhm.
It's absolutely devastating. One of the most challenging aspects of, like, for example, the breast cancer and the cervical cancer, we know they're very much connected to a woman's reproductive health. And we know a woman's identity a lot of time is based on her ability to have children, is based on her physical appearance. So when you have a woman who's 25 years old with cervical cancer, her first thought is, what's going to happen to my relationships? Is anybody going to want me if I don't have, if I'm not able to make children, if I'm not able to have intimate relations? And with the breast cancer, again, that is part of a woman's unique identity. And when you start talking about taking it off, that could be extremely devastating. And a lot of patients sometimes try so hard to hold on to that malignant tumor, even though it could cost them their life, because the thought of not being seen as feminine was really a hard blow for them to have to take.
But what can you tell somebody like that, like a female who is thinking about losing her reproductive organs? What sort of counseling can you possibly give to someone like that? Because as you said, your reproductive organs, women connected to their identity as a woman. But what do you tell somebody in that condition?
Well, we have to help that individual to recognize, first and foremost, life is way more important than how you look physically. It's easier said than done, eh? It's always nice to say these things like sound like they're coming from a book, but in the reality of it, when you're sitting across from a patient, that is how society views them. So we're trying to say you're beautiful regardless of whether you have one breast or two. But what does society say to them? What do the movies say? What do the love stories say? They all show an image of a woman that has both breasts and everything. So you're saying this, and that is why it's important for us to have this support system for the family to reinforce it. That's why we also bring in the woman's partner so that when we say one thing at the health centers or in the counseling sessions, that partner can reinforce it. So we help the woman to find a sense of self that goes bigger than just who she is physically. We try to remind her, look, you're a combination of so many things. So if a breast is gone, you have your intellect, you have your arms, you have your eyes, and we try to help her to rebuild her self-esteem and her sense of self and her sense of beauty. And it's a process. It does not happen overnight because there are other mitigating factors also.
All right, thank you so much. Dr. Andrea, we're going to go back to you. What are some of the most common types of cancers you have seen in your practice?
Well, Ms. Norton alluded to some as well. Breast cancer, very common, especially in our population, and prostate cancer as well, very, very prevalent in our population. And now, one aspect of prostate cancer is that when it spreads, metastasize, it usually goes to the spine, and that can actually affect the spinal cord. So we see quite a number of patients. Unfortunately, it's a fairly late stage where they're now losing function in their legs, losing their balance and their ability to stand, walk, sit up. It's very challenging at that stage because the spine can be very brittle. So it takes a lot of care in being able to work with such patients. So you don't really want to be too aggressive because the spine is brittle, it can get worse, but you still want to try and maintain as much mobility as possible gentle exercises. Sometimes, if they're unable to move their legs, we have to move it for them so that they don't get stiff, contracture again. Then, with the breast cancers, we find that we get generally better outcomes with this population because they would come a bit sooner than, let's say, the late stage in terms of the male prostate cancer. So a lot of them have, as Ms. Norton alluded to, if you had the mastectomy, remove the breast. And so there's actually scarring and what you would call lymphedema as well, especially if the lymph nodes are affected. Now, lymphedema is basically swelling in the limbs due to a disruption in the lymphatic system. All right. So, as I said, lymph nodes removed, they can get a lot of swelling. We have some physiotherapists that are actually trained for lymphedema management. Okay, Dr. Raisa Sabimana, she actually did a course recently, so she mainly does it at the hospital, along with a few others. It incorporates a lot of bandaging, sometimes, and exercises, sometimes some massages as well to help reduce the swelling as much as possible. Um, Also, with the scarring itself, they can have difficulty moving the arm, they lose function of the arm. So something as simple as overhead tasks, cleaning, can be lost or disrupted as a result of the surgery. And so then we have to start with gentle stretching, range of motion exercises to as soon as possible to maintain that and prevent it from getting stiff. Then as you go further, you can have bone cancers and nerve cancer, brain tumors, as again Miss Norton made mention of. Brain tumors can be pretty devastating. We do see a number of patients who have brain tumors, and so the tumor removal itself the patient needs physiotherapy to basically walk against it. Again, basic things. Some may present even in a stroke like manner, some present with just general weakness, some present with paraplegia, and so they take a lot of work. We've had quite a few success cases though. Basically taking a patient from sitting up to walking and back to work takes a lot of patience as well because it can be very frustrating for the individual, as Miss Norton would better be able to explain. One day you're good, and then the next day you're depending on others for work, for bread, because you can't work. And so working with these patients over months, you get to see all that part of it as well, the emotional turmoil it takes on them. But we start with the basics. We do the balance training, general exercises. You try not to go too heavy, because when you're weak you can damage your muscles. And then we progress the exercises, start with basic tasks such as feeding yourself, until we get to a point where we say, okay, we've done all we can and you've improved to a degree, and then you're ready to continue to live your life, so to speak.
All right, thank you so much, Dr. Andrew. Good evening, Carol, Esther, Henry. Thank you so much for tuning in. Remember, those of you who are joining us, remember to share the live. Dr. Peters, what exactly is pain management and why is it important for patients to understand pain management?
Okay, pain management is basically control of pain, reducing pain as much as possible. Pain is one of the most debilitating symptoms anybody can have. I'm sure everyone here has had some pain, whether it be back pain or whatever pain, and you can barely move. If you don't manage pain, movements become extremely difficult. Now, in relation to patients with cancer, it's not as easy, let's say, when for physiotherapy to help when the cancer is not in remission, because certain modalities we use for pain management can actually increase circulation and spread the cancer or make it more aggressive. But usually when patients are, in remission or having their chemotherapy or radiotherapy, they come to us again with the joint pains and so on. We can use heating modalities, again, the stretches, light exercises, massages where applicable to help manage the pain so that they can continue to function.
Thank you so much, Dr. Peters. Now, Miss Norton, you would have spoken about the treatments available for persons that have been diagnosed with cancer as it relates to the psychosocial aspect of cancer. What are some of the coping mechanisms do you have in place for family members of cancer patients and friends that are just seeing their loved ones go through hardship and pain and suffering during this time?
Okay, a key aspect of the treatment is involving the family members. Um, the family members have a very integral role to play. And when I was listening to Dr. Peters talk about the patients and all that they have to go through. I do remember accompanying a family member to the physical therapy department and having to see what that person went through for their treatment. And being there as a family member, it gives so much insight because I learned more about my family member's illness. I was able, Dr. Peters and his staff are incredibly welcoming and professional and very competent, and they were able to show me as a family member, how do I help this patient when we get home. So, as a counselor and doing with the interdisciplinary team approach, we all work together. So, when I, as a counselor, say to the patient, you know what, and the family members, you need to take your physical therapy really seriously. You need to make sure you take your meds. You need to make sure you do A, B, and C. When they get to the physical therapy department, that family member sees exactly what goes on. So they don't say when the person comes home, oh, you're just crying for nothing. They would have seen everything. And the other thing is the persons in the physical therapy department, they do their own counseling. They're very motivating. They push you. You know, they would say to the patient, look, you came in the wheelchair today. By next week, I want to see you walking in. And that is so helpful for the patient and it's helpful for the family member because it provides hope, it provides motivation. So when I meet with family members, a lot of the time they feel sometimes physically tired and exhausted because they would have taken over a lot of the care, like care of the children. They would have had a lot of the financial burden. They would be the one driving to and from therapy 2 and 3 times a week. They would be sometimes feeling guilty because they feel like if I were doing something I was supposed to do or encouraging him or her to get their checkups regularly, he or she would not have had cancer. So sometimes there's some guilt, the physical exhaustion, the mental tiredness, and then you don't want to complain as a family member because you feel like I'm not even the one in the situation. So what do I have to complain about? But you really also, as a family member, need support. You need to be able to vent. You need to be able to express your anger at the fact that everything is now on you, at the fact that you feel so helpless, at the fact that there are limited resources. So family members really have it hard. And then when you're only allowed a 1 hour sick lunch break from your job, and you have to bring your family to therapy, take them back. You can't find medications all over Antigua. Family members need support. They need to understand what not to say to the patient and what to say. They need to understand how to motivate the patient and still leave a little bit of emotional well-being, self-soothing for themselves. So it's a very delicate balance, but family members definitely need support the same way the patients do.
Where can family members find support in Antigua and Barbuda?
Well, the ideal scenario is if we had more support groups. We do have a couple of support groups, Cancer Society, and it's really, really helpful because I've attended some, and it feels so good when you get up as a family member and you're sharing, and sometimes you're a little hesitant, right? And then somebody says, I know exactly how you feel. That validation means everything. For somebody to say to you, I understand, I know exactly how you feel. So it's important to have a support group of family members of persons coping with cancer. Sometimes we refer them to a minister. Religion and spirituality in the Caribbean and around the world play a very, very big role in psychosocial support. For a lot of persons, they have their Bible text, they have their Psalms, they have their gospel music, they have their church, their prayer warriors group, and that means a lot. So we refer them to their minister if that's applicable. We refer them to the support groups, and sometimes we refer them to these nonprofit organizations like the Rotary Club, the Lions Club, and places like that that also give support. And one of the things we need to do to backtrack a bit is when we're deciding what sort of support to give, it's always important to do an assessment because there's no one size fits all approach. I might think, okay, this person is into God. So I have a list of scripture that's useful for healing and for strength and all that. And I can give it to that family member, that patient. But then the next person that walks into my office might not believe in a God per se. They might believe in nature or just karma or something like that. So there is no one size fits all approach. We must assess the patient to see what is your financial status, what is your religion, um, what are your values and all that, so that whatever care package we present must be suitable for that particular patient and the family members.
All right, thank you so much. And how, in terms of the spirituality, because previously we would have interviewed several cancer survivors and they would have noted the important role spirituality has played in their just going through the entire process. Based on your experience, how do you think spirituality has helped cancer patients overall, just from your assessment? Do you think
Well,
spirituality has helped them to live longer, look at their life from a more positive perspective? How has it helped?
absolutely, absolutely. I would want to hazard a guess and say perhaps at least 80% of the clients I have seen have had some level of spiritual connection. And I would want to say, without a doubt, it makes the world of a difference. Because one of the things about persons who believe in spirituality is that this present moment is not everything, you know? There is hope for a future. Some people believe in a heaven where there's no more pain. Some people believe that there's a God that cares for me. And they open the Bible and they will tell you, if Job went through this, then I can go through it too. And they have a song for everything, they have a scripture for everything, they have a point of reference for everything, and that makes a world of a difference. And guess what? As a counselor, sometimes you set up a session and you all prepared. I'm going to really sit with this person. I'm going to listen and I'm going to give as much as I can. And guess what? Some of these patients walk in, right? And because of their level of spirituality, it's almost as if they're increasing your own hope and your own strength because they're so positive and they're so motivating that it really, you can see the difference in their faces when they have that hope and they have that fight. It makes a world of a difference. So I will, even if as a practitioner we don't necessarily believe in a God or something, it's really important when we're speaking with clients to find out what is that client's value system, what is this client's strengths, what are their coping mechanisms. And it's always important to ask the client, what has worked for you in the past? Most of us don't get to the age of 30, 40 without having gone through some challenge. So if we want to know what tools to use for this particular client, ask the client, what has worked for you in the past when you've been in pain or stressed or depressed or something like that? And if spirituality is something to them, then ask them to put that in their toolbox to pull out when they need it. It's really a cure for the depression for some of those cancer patients and families.
All right, Ms. Norton, thank you. I believe we have a question for you, for those of you. But before I ask the question that are tuning in via our social media platforms, remember to share the live. And if you have a question, feel free to leave it in the comment section. Our panel will be more than happy to respond to your questions. Now, we have a question from Carol Esther Henry. How do you get other family members to support a family member who feels that everyone dropped the task on him on her or her? So, how do you get other family members to support a family member who feels as though everyone has dropped the task on him or her? I believe
That's
this is for
really an
you, Miss
important
Norton.
question. It's really an important question because oftentimes, if there is one particular family member who might be unemployed or self employed, everybody makes the assumption that, okay, he or she has all the time in the world, so I'm going to leave him or her to do all the work. However, caring for somebody with cancer is not just about having time. So even though Peter might have all the time in the world and Peter's taking the patient to therapy twice a week and taking the patient to the cancer center and buying all the fruits and vegetables, Peter is still emotionally drained by having to see the person in pain, by having to hear the screams, by having to buy gas for the car. So, what we usually do as social workers and counselors is that we ask all of the family members, as much as we can fit in the boardroom. A lot of the work I did was pre COVID. So, we weren't that concerned about space at that point. Now it's a bit more challenging. You'll probably have to meet them on Zoom, but we try to bring as many concerned persons as possible because it is too much to expect one family member to do all the work simply because she lives with the patient or simply because he has more flexible hours. Even if one person has more time, somebody else might be able to cook, somebody else might be able to donate some money, somebody else might do the shopping or the cleaning. So we try to use a collective approach. If you have a burden to bear that's 50 pounds and one person is holding it versus five persons with 10 pounds each, tell me what would be easier. So we have to work together as a group and we have to take turns. Even if it means taking shifts. I'll be with a person from 3 to 7, you come from 7 to 10, and we make it work. But it's not good enough to leave everything for one person. Financially, time wise, no kind of way.
All right, thank you so much, Miss Norton. Dr. Andra, we're going to get back to you, but before we have greetings from our very faithful guest, Alma Brooks, all the way from Hawaii. Thank you for tuning in, Alma. Dr. Andre, we're going to look at breast cancer. Now, we're highlighting breast cancer in the month of October. Can you tell us what are some of the exercise like persons need in order to maintain function in the arm to prevent fluids from getting back in the body?
Good question. I presume you're referring more to like lymphedema, like the
Yes,
swelling in the limb.
yes.
Okay.
Mhm.
Sometimes it's just simple mobility. All right, get the heart pumping, get the limbs moving, return the circulation. Okay. Upper extremity exercises, something that you can do at home. Just use a broomstick up and down. The funky chicken, so to speak. Stretches, all those exercises, help with the circulation as well as any contractures or scarring, stiffness that you may have as a result of the treatment or even the surgery for the breast cancer.
All right, you actually answered the question I was going to ask you, like some of the exercises that you could do after the surgery.
Mhm.
But Miss Norton, we're going to go back to you. Now, we looked at some of the coping mechanisms persons can, well, the family members can use after they would have recognized or known that their family member has been diagnosed with cancer. But what about the patient itself? What type of coping mechanisms do you have it? Well, can patients actually use in order to, go through such a challenging experience overall?
Okay, the coping mechanism. for the patient would depend a lot on what the patient is struggling with. Like I was saying earlier, I don't believe in the one size fits all approach. So if I'm going to work with somebody, and most counselors do the same thing, you sit with that patient and you want to find out from them, who do you live with? Do you live alone or do you have somebody with you? Where do you work? Is it some place that you're comfortable sharing with your coworkers what you're going through, or you'd rather keep it a secret? Do you have a history of depression or bipolar disorder or something? What is your interaction with faith and spirituality? What sort of exercises do you do? What are your hobbies? And when you've received a profile of who this person was before cancer, then you can try to help them develop a toolbox. I love the toolbox analogy because you think of this box and in it you have like a hammer or this or that. So what I help them to develop a toolbox, not a literal toolbox, an imaginary toolbox, but you imagine that these are all the things you like doing and we put it in there. So in the moments when you get really down and depressed and want to give up, you pop open your toolbox and you pull out something. So it depends a lot on what matters to the patient. If this patient is a mother who has children that she absolutely adores, then that can be used as one of her coping skills. She wants to see them graduate. She wants to see them get married. She wants to have be a grandmother. And if you can connect her with her need and her love for her children, that will make that woman fight so hard to live. There are very few women that will not put everything, all the fight and strength they have into their well-being when they have young children that they want to see grow up, that they don't want anybody to take advantage of. And then we have some persons in romantic relationships who has a partner who's supportive. Then we use that as a coping mechanism. You're not going to always have somebody around you. And this is the part that's very difficult because sometimes you go to church, sometimes you're at work, but the hardest part is when you are alone with your thoughts, especially for our patients at night. Because a lot of the times, I don't know what it is about night, but in the night, sometimes they feel more pain. Maybe Dr. Peters has an answer for that. Or maybe it's because he worked them during the day while they're in pain at night. I don't know. I'm not going to blame him. But at night, the pain seems to be worse. And you know what happens to our patients at night? They have a lot more time to think. And that's when you find a lot of the depression and the thoughts coming. What if I don't make it? What if he leaves me for another woman who has both breasts? And for the men with a prostate, what if I'm not able to satisfy her? How am I going to pay for this treatment that we can't afford here? I have to fly to Barbados. This is the time when it comes. So this is the time we say to them, look, you pull out your toolkit. If journaling is what works for you, get everything out of your head and onto a piece of paper. It doesn't have to make a lot of sense. Just get it out so you'll be able to sleep. If music works for you, have your YouTube playlist. If the scripture works for you, have that. Have 3 or 4 friends on WhatsApp or speed dial that you can call. Meditation works for a lot of people. Just sitting there and trying to empty your mind. Visualization works for some of our clients, the ones who have an active imagination, so that when the pain is racking their body, they can close their eyes and just imagine they're on a peaceful beach and the waves are there, or they're in a hammock, or they're on a flight to New York. Again, it depends on what matters a lot to that person. So we use visualization, we use journaling, we use support system, we use music, we use art. Some people use pets. A lot of our clients having a pet, gardening, walking on the beach. So there are a host of different things we can do. What we want is for this client to not give up on life. What we want is for our clients to know outside of the pain and the suffering, I can have a full life. I might not be able to go to work 5 days a week, but I can make arrangements with my employer to work from home 2 days a week. So these are the kind of things we do to help persons to have some level of self-worth and feel like they're still contributing to society and all is not lost.
Thank you, Miss Norton. Dr. Peters, to answer the question that Miss Norton posed, why do you think patients experience more pain at nights?
That's a good question. I don't want to be quoted, but from what I understand, it could be like hormonal changes, like I think cortisol. certain hormones drop in the night or something like that. Sometimes temperature changes. If it gets cold, you might have more, joint pain, so to speak. But again, I don't want to be quoted on it, but you're very right about that. And actually, I think one of the symptoms they would say pain at night or night pains could actually be one of a symptom of cancer, basically. You know, so that is something I definitely would like to do a little more research on.
Okay. All right, so we have a comment from Carol. She's saying, Corin, those are excellent tools to refer in alone time. Thank you, Carol Esther. Now, Miss Norton, we're going to look at bereavement. Explain to us what exactly is bereavement and what are some of the most common types of bereavement that persons experience when dealing with cancer. Well, after
Okay.
somebody for them would have passed on from cancer.
Okay. The thing about bereavement, right? A lot of the times we think that bereavement comes when somebody dies. But what I want to tell you, and Carol can attest to that because she's very knowledgeable in these areas. You know what happens? Sometimes we have a patient with a diagnosis and we've tried everything. We've tried everything. And maybe because it's the lateness of the diagnosis or for some other reason, the patient starts to deteriorate really and truly. They start losing weight, not being able to eat, maybe vomiting and bleeding, and the symptoms are really getting worse. Do you realize that the bereavement process can start from that point while the person is still alive? Do you know what it feels like to have a family member that used to be vibrant, that used to love dancing, that used to love carnival, that used to be the life of the party, and all of a sudden this family member is 95 pounds, laying in a bed, skin and bone, and you have to watch that. The grieving process starts right there. They don't even have to wait for the person to pass. However, because it's sort of like a preparation. And when the person does pass away, then you have the actual loss, and you have to deal with the fact that this person is not coming back. The strange thing is, in many cases, we have a deep sense of loss because we no longer have somebody we love. But one of the strangest things that happens, some family members feel a sense of relief. But with that sense of relief sometimes comes guilt. They feel a sense of relief because they're physically tired. It was a 5-year battle. And they feel a sense of relief because it's not easy to hear your family member screaming in pain in the bedroom next to you, right? When they're in hospital, they might have access to morphine or something. But if you can't afford, you have to take them out to the hospital. You can't afford hospice, and you have that patient with you there, and you're gonna hear their screams. You're gonna hear them begging you to help them, and it gets really bad. So there's the bereavement that starts when they start deteriorating. There's the bereavement that comes when you actually lose them and you know they're not coming back. And you also grieve for the children. You grieve because you feel a sense of guilt. Sometimes you wish you could have done more. Sometimes you feel a sense of anger. So the grieving can be very complicated. It could be very dramatic. Sometimes comes with a sense of peace, sometimes with a sense of unease because it means now the rest of the family have to go and get certain types of tests to see if they're prone to having that same type of cancer because we know some of it comes in the genes. So the grieving process can be very complicated depending on the situation.
Okay, so what exactly is bereavement counseling?
Well, bereavement counseling is helping the person who is the family member or the survivor to cope with the loss of their loved one. So the bereavement counseling is helping the person who's left behind to cope with the loss of their loved one who is no longer here.
But can bereavement counseling begin before? Because you said bereavement begins before sometimes the passing of someone. Can this counseling process begin before?
Yes, you can begin it before in a preparation sense. You can begin preparing the patient for the end of life. I think a lot of counselors are reluctant to do that because we don't want to play God and we don't want to jump the gun. So even if for 98% of the time you know that patient is not going to last very long, a lot of family members don't want to hear that. Maybe they see it too or they don't, but when you put it into words, it becomes more real. So a lot of people are in denial. So most counselors do not do a lot of bereavement counseling before the patient actually passes away because it sounds presumptuous and the family members sometimes get angry because they're not always ready. What we do instead is that we sort of prepare the person. So we would ask questions like, in the event your family member is no longer with you, have you thought about where you would live? Have you thought about what you would do? Have you thought, and you look at end of life care and preparing for like estates planning and all that sort of thing. So yes, you can have a discussion to prepare for when the person leaves, but you have to be very, very careful of how you introduce that topic. Not everybody can deal with that.
All right, we have a few comments. A comment from Miss Lydia John Baptiste, very comprehensive and thorough response by Miss Norton concerning coping mechanisms. We also have from Carol Henry, grieving can be traumatic as well. No, and then we also have another comment from Carol Esther Henry, absolutely sensitive areas. Now, before we go back to Dr. Peters, and as we wind down tonight's discussion, remember for those of you who have any questions, comments, remember you can leave your comments via any of our social media handles. Our panel will be more than happy to respond accordingly. Ms. Norton, is there anything that can be done to reduce the trauma that comes with grieving once the process is started before the person has passed on?
Well, to be honest with you, I can't remember how many years I'm doing counseling now. It's probably over 20 years. I wish, I wish with all my heart that there was an easy way to do grief counseling and coping with loss. I really wish. But the reality is, we are human beings. We have hearts. We're created to feel. And while we try to ease the burden with all some of the same coping techniques we spoke of before, for those who are Christians that believe in heaven or life after death and all these sort of things, this can be the strongest source of support for most persons because they believe in the earth made new that we're going to be meeting with our family members again. For those that have no spiritual beliefs, it becomes a little harder because some of them believe death is the end. So we help them to cope by finding a support system, by telling them to acknowledge your pain. Nothing is wrong with crying, nothing is wrong with hurting, and we have to normalize the process of dealing with pain. If we try too hard to do away with grief, we're going to tell people, look, something is wrong with you for grieving. So go drink some rum, go smoke some weed, go and spend all your money on Amazon, max out your credit card, go on the gambling or the porn sites. We don't want to put a plaster over a sore. I think it's normal and I think it's human to be able to grieve, to be able to cry, to be able to say I've lost my best friend, to be able to say I don't know what life will be like without him. I think it's normal. So while we try to ease the pain by helping people to find others to hold their hands, to sit with them, to look at the hope and the future and look for those who are left behind because you still have other people who love you and who need you. So while we encourage them to do all that, I do not want anybody to get to the point where they're no longer feeling. So there's a balance. We have to grieve because we're human. Jesus wept. Let's embrace it and it will help us to have empathy for others and it will help us to be more sensitive to situations.
Thank you. Very insightful, Miss Norton. Dr. Peters, Is physiotherapy an absolute requirement for cancer patients?
I would say yes. Um, Now, whether or not it's absolutely necessary for them to access a physical therapist is a different question. But physical therapy begins with the individual. Something as simple as getting up and doing some exercise, taking a walk is aerobic exercise. Studies have shown that low intensity to moderate aerobic exercise generally really makes a difference for the fatigue that persons, either with cancer or going through chemo radiotherapy. It makes a difference. So again, the exercises, if you don't
But does it
move it, you
reduce
lose it.
the pain? Does it
It can,
reduce the pain?
it can,
But
because
is it temporary or is it something, if you keep doing it continually, you will eventually not
no,
feel the pain?
no, no one size fits all, as one of our viewers said. It all depends so much, and it's very difficult for persons to grasp sometimes that zero pain is almost not realistic. But
Mhm.
what it is with pain management is low amounts of pain, or pain that doesn't stop you from living and laughing and doing things that you want to do. So that's usually how I approach it personally. If you come in with a 9 out of 10 pain, our first mission is to reduce the pain. Okay, we can't really look at a 0 to 10 when you're coming in with a 9 out of 10 pain. Let's get it to 7. Let's get it to 6. Tell me about your task. You're paying so much that you couldn't move yesterday, but today now you managed to go and fix yourself a meal. Then we managing the pain, we improving with the pain, and it's a tricky little thing, because pain can stop you from moving, but not moving at all can cause you pain. I
Mhm.
guarantee you, if you lie down in a bed for a week, you're going to be in pain. We're not designed to be stationary. Okay, I mean, sure, you've been on a long drive. You've been on a drive for more than 2 hours. You're in pain. So it's about finding a balance, with movement in regards to pain management.
Now, as a physiotherapist, how does it affect you seeing people, especially children, experience a lot of pain? Does it
And
affect
that,
you mentally?
yes, yes, it's not easy. I try not to show it because, I mean, persons come to me, in hope. I can't be the one going on, and then there's the two of us going on. So I try to be strong, for the patient, but it's not easy. Whether child, middle age, elderly, I don't like to see people in pain. I don't like to cause pain. Some of our interventions may be initially painful. It's not easy, but try to stay upbeat as much as possible. That's how you survive in healthcare. And I sure it's not no we tell you in counseling. It's similar. You have to stay upbeat.
I have a few comments.
Yes, yeah. Miss Henry's Mrs. Henry is very right.
I'm I'm not hearing.
During grief, we can try to get them to see that all is not lost. Life is filled with many positives despite the negatives. Now, we have a question for Dr. Peters from Mr. Jason Hudge. Dr. Peters, what sort of therapy would you recommend for someone who is on the chemotherapy treatment?
Okay, good question. Again, it all depends on how the patient presents. Chemotherapy, pretty broad spectrum, can cause fatigue. So again, low to moderate intensity exercises. Chemotherapy can and radiotherapy as well can sometimes affect the nervous system. So weakness, balance issues. So we're looking at starting with gentle strengthening exercises, balance exercises. Um, Sometimes chemotherapy can cause some pain, stiffness in the joints. So we're looking at joint mobility. Again, if the cancer is in remission, we can try the heating modalities as well for the areas that are on the pain, stretching. as well. So it all depends on how the patient presents. Not every patient presents exactly the same.
All right, Miss Norton, we're gonna go back to you as we wind down this evening session. Remember, those of you who are joining us, if you have any questions, feel free to ask your questions. We're about to conclude this evening session. Any final remarks, Miss Norton? What would you like your audience or our viewing audience to take away from tonight's message as it relates to um, counseling, psychosocial counseling? What would you like them to take away from tonight's session?
Okay, well, for persons, the first thing I would want to say to everyone is let's try to focus sometimes on prevention. We've been talking a lot tonight about the experiences of person who had positive cancer diagnosis. And if we were to try to focus on prevention, then we would not need to go so far sometimes. So let's try to continue to eat healthy, to exercise, spend time in the sun, have a positive outlook, get our checkups as early as possible. And then for those who've actually received a positive diagnosis, and also in the prevention category, we all know, we've heard 100 times that they say early detection is important. So we need for the men to get our prostate checks. A lot of the times, Lions and everybody has them free. Women, we need to get our pap smears and our breast checks and all that. So let us do a lot of that and let us teach our daughters and our sons to take care of their health in a preventative way. And if it so happens that we get a diagnosis, it's not the end of our lives. We can fight it. We have excellent care team in Antigua and Barbuda, and I'm sure around the Caribbean and the world. So as soon as it comes, don't worry about being embarrassed or ashamed. We don't have time for that. There's no stigma and discrimination attached to a diagnosis. It's not, anybody's fault. The point is you're ill, get help as soon as you can, and have a care team. Do like the Avengers. Have your own posse of everybody. Make sure you have your doctor, your physiotherapist, your nurse, your dietitian, your counselor, your social worker, and two or three other survivors. Keep them a list somewhere and make sure you utilize everything. What we are going through are what others have gone through before. So learn from their mistakes, learn from what works for them. But a diagnosis is not a death sentence. And for the caregivers, I would like to say thumbs up to the caregivers. Sometimes you feel invisible, but we see you. We know you're there. We know you're putting your hands in your pocket. We know you're driving persons to therapy. We know you're buying all the insure and the vitamin waters. We see you and we appreciate what you're doing and make sure that as a caregiver, you make some time for your own self care. We don't want you to give and give to the point where you feel bitter and resentful because you're the only one doing everything. So ask for help if you need it also and try to share the work. And for our healthcare professionals, Dr. Peters and the others, I want to say thank you for the excellent work you've been doing and for the Cancer Care Society, Dr. Sister Benjamin and everybody else. I just want to say thank you. Keep up the good work. And I want to ask the healthcare professionals to focus a lot on educating patients. A lot of the time, the patients don't understand some of the big terms we're using and all these details. Educate the patients and refer them as much as possible to the other aspects of care, like the psychosocial physiotherapy and that sort of thing. So that's it for me, and I really appreciate the opportunity to sit in such esteemed company to spend some time with you all on this topic.
Thank you so much, and it was a pleasure having you. Just a few comments before we turn over to Dr. Peters. Logan and Wright, very great presentation. Carol Esther, I like alternative treatment. Also, Nurse Benjamin, great session, awesome panel. And let go them fatty foods, so the KFC and all them nice food. Lord help us. From Carol, it's very hard to let go. Sometimes people eat based on what they see. They don't think about what they're putting in their bodies. So I think that is something we probably need a dietitian to come or a nutritionist to come and tell us about the type of foods we should eat on season 3, which will be in November. Dr. Peters, any final remarks from you?
Well, Miss Norton basically said, so many excellent things. I don't have much to add. I like her mantra about the prevention. It's a proven um, study that obesity is linked to cancers, as well as not eating fruits and vegetables. So yeah, I'd like to echo that. Just try and prevent it, rather than always trying to fix it after it done happen.
All right. Thank you so much, guests, for tuning in. And I would also like to thank all of you who are joining us via Facebook, Twitter, and YouTube. Good evening to you, Siobhan. We have a very diverse group of persons tuning in. We have Mr. Stevens tuning in from Canada. We have Logan Enright from Arizona. We have someone from Alma Brooks from Hawaii. Carol Esther from Antigua, Leslie Hudge from Anguilla. So thank you so much, Lydia Baptist from Antigua, and the others who are joining us live. Thank you, thank you, thank you. And we have Francine James saying, great job, everyone. Thank you to everyone who have been tuning in to our cancer awareness program. And thank you to our very special panel, Miss Norton and Dr. Peters for gracing us with your presence and providing some much needed insight. Next week, we will continue the discussion with Nurse Imelda Benjamin, a cancer survivor, and Dr. Nandan Shambhat, an oncologist at the Mount St. John Medical Center, as well as Unetta Bird. She is also a cancer survivor and president of Breast Friends, and we'll be discussing palliative care. So you don't want to miss next week's session, same time, same place. Remember to tell a friend, tell a coworker, tell a family member that the Apex of Training and Development show is inviting you to be a part of our cancer awareness program. Once again, thank you everyone for joining us. Thank you to our great sponsors, Nagico Insurance in Anguilla. Thank you so much for sponsoring our program. We also have a final comment from Roberta Ephraim, who is one of our faithful viewers. Thank you very much for yet another truly informative program. Thank you, thank you, thank you. And remember to stay safe. Remember to use all the advice and all the practices that were given this evening, incorporate it in order to live a more healthy life and in order to help persons that you may know that are actually that have been diagnosed with cancer. Once again, good evening. Have a wonderful evening. It was a pleasure being your host as always. My name is Cherry and Casimir Hudge, and stay safe. God bless you. Good night.